Dear students, let's see about antiretroviral drugs today. The learning objectives will be, you will be knowing about the pathophysiology of HIV infection, classification, mechanism of action, pharmacokinetics, adverse effects and drug interactions of various antiretroviral drugs, principles of management of HIV/AIDS, post-exposure and prenatal prophylaxis of HIV infections. So these are the different retroviruses. Okay, so the retroviruses which are of concern to humans are delta retrovirus and lentivirus. Delta retrovirus is the human T-cell lymphoma virus which cause T-cell lymphoma and neurological disease, and the other most important virus is the lentivirus, which is HIV 1 and 2. So, and this causes AIDS. So HIV, human immunodeficiency virus, it is an infection that attacks the body's immune system, okay, especially the CD4 T helper cells. And what happens? So it destroys the CD4 cells, and if the person's CD4 count it falls below 200, then their immunity is severely compromised, which leaves them susceptible to various opportunistic infection. So whenever the CD4 count falls below 200, then with coexisting opportunistic infection, then the patient is said to have AIDS, acquired immunodeficiency syndrome. And this is the structure of human immunodeficiency virus. Okay, so here you have, so this is the nuclear capsid, okay, and it is a RNA virus. So HIV virus is a RNA virus which has two single stranded RNA, and then which is surrounded by the lipoprotein membrane. Okay, so the most important enzymes which are present inside the nuclear capsid are reverse transcriptase enzyme, okay, which is an RNA dependent DNA polymerase, and you also have many other enzymes like integrase and protease. Okay, and in the cell membrane there are two important proteins called as GP120, glycoprotein 120, and glycoprotein 41. So these two protein molecules, they are essential for the attachment of the virus to the host cells. Okay, so that is the CD4 T cell. So these two are essential for the attachment of virus. Okay. Okay, so this is what happens when the HIV comes and gets attached to the CD4 T cells. So you can see here, this is the GP120 and GP41. So this stalk-like thing is the GP41. Okay, it is a transmembrane protein, and GP120 is the capsular protein. So this virus, it comes and gets attached to the CD4 cells. Okay, so there are these receptors, okay, the binding receptors in the CD4 cells have some co-receptors also. Okay, so chemokine receptors we call them as. So these chemokine receptors are CCR5 and CXCR4. So these two are co-receptors which helps in the binding of this HIV virus to the CD4 cells. Okay, so these are called as chemokine receptors, and this is the CD4 receptors to which this GP120 comes and gets attached, and this GP41 helps in the fusion. Okay, so the attachment is carried out by the interaction between GP120 and the CD4 receptor, which is helped by these chemokine co-receptors. Okay, and GP41 helps in the fusion of the HIV virus into the CD4 cells. So then the virus enters inside. Okay, so there is uncoating. So the outer membrane gets uncoated, and the nuclear capsid alone comes here, and then the RNA which is present, most usually what happens, RNA gets translated into proteins, but here the RNA gets converted or transcribed into into DNA. So it is a reverse process. Usually transcription occurs from DNA to RNA in human cell, but here the transcription occurs from RNA to DNA by an enzyme called as reverse transcriptase. Okay, so then for the daughter DNA is produced, then the double-stranded DNA is formed, and then this DNA this is the proviral DNA, and this DNA enters into the nucleus of the host cell and gets integrated into the host cell DNA. Okay, so this proviral DNA gets integrated and becomes a part of the host cell DNA, and then transcription occurs. So this DNA contains codes for synthesis of various proteins of the viruses. Okay, so here after the transcription, what happens, again the RNA is produced. So RNA gets translated into various viral proteins, and then these viral proteins gets assembled, okay, into active virus. Okay, so this active virus gets fully matured by the action of protease enzyme. So this protease cleaves the various pro-protein substances. Okay, so after translation, the virion contains many big protein molecules. We call it as pro-protein molecules, and these pro-protein molecules has to be cleaved into active protein molecules, like the capsule protein GP120, GP41, and the other the viral proteins. They are cleaved. The active viral proteins are formed by cleavage of this pro-protein substances by an enzyme called as protease. Okay, so after this active protein molecules get assembled, then the virus it is released. The active virus is released out of the cell membrane of the CD4 T cells. Okay, so this lipoprotein membrane, this is got from the host cell membrane during the process of budding. Okay, and now this virus again infects the other CD4 cells, and this infection goes on and on. So this is how the HIV virus infects the CD4 cells and replicates itself. Okay, so you can see this is the electron microscopic view of this HIV particle budding out from the CD4 T cell. Okay, so what happens when the infection with HIV occurs? So first there is a primary infection. So whenever the patient gets infected with the HIV, so there is a stage of primary infection. So after this, after a lag time of 3 to 6 weeks, the patient present with acute HIV syndrome. Okay, so which consists of fever, myalgia, lymphadenopathy, sometimes meningitis. Okay, so this acute syndrome, during this phase only there is wide dissemination of the virus, and when you measure the virus RNA, there will be high viremia. Okay, the plasma viremia will be at a very higher level during this phase, and this acute syndrome, after 1 week to 3 months, okay, it gets settled down. Okay, your immune system fights the virus and keeps a check on the viral load, and the acute syndrome slowly subsides because of active immune response to HIV. Okay, so after this, after 1 to 2 weeks of this, the patient goes for a clinical latency period. Okay, so there is a latent period during which the CD4 lymphocytes, it gets gradually dropped down. So primary infection followed by acute syndrome, then the patient settles because of the CD4 cell count comes back to a normal, and the plasma viral load reduces, okay, the plasma viral load reduces to a negligible level. But the HIV virus goes and gets hidden in the lymphoid tissues. Okay, so there is always a persistent infection in the lymphoid tissue. The virus persists and slowly the CD4 cell count starts to reduce. Okay, so but then during that period there are no symptoms, so the patient appears completely normal. Okay, but the CD4 cell count keeps on decreasing because of the persistent latent infection in the lymphoid tissue. So after years of clinical latency, so when the CD4 cell count falls below 500, then the patient will be in an immunocompromised state. Okay, then it falls below 350, 200, then the patient will start acquiring opportunistic infection. So the patient is said to have AIDS. Okay, so which may be fatal if untreated. Okay, so this is the course of HIV infection. Okay, so this is the graph showing the course which we were discussing. So this blue line, no, this is the viral response, and this red line, the blue line is the immunological response, your CD4 cell count level, and this red one is the viral load. Okay, so here this is the point of acquiring the HIV infection, primary infection, and then this primary infection, it after this primary infection, the viral load increases, okay, to an enormously high level, and then which is followed by fall. Okay, so after this, so this is where the acute HIV syndrome presents. Okay, so after this phase, after this acute phase, what happens? You can see the viral load gradually got reduced. Okay, then it is almost kept under a check. Okay, so there is a plateau phase in which the viral load doesn't increase, so it remains latent, or it remains persistent in the lymphoid tissue. So this is the clinical latency period. So after few years, so you can see here 1 to almost 6 to 7 years. Okay, so after few years, what happens? Again, the as the CD4 cell count gradually falls down, again what happens? Your immunological system of a body no longer can contain the viral load, so your viral load start to increase again. Okay, so then again the patient will have constitutional symptoms, and as the viral load keeps on increasing, then opportunistic infections, and finally death if left untreated. And the same thing is, you can see here the CD4 cell level after the primary infection, there is a sharp decline in the CD4 cell count, so which correlates with the peak viral load. Okay, so when the viral load is at the peak, there is also a peak decline in the CD4 cell count. So this is the acute phase, and after the acute phase, gradually the CD4 cell count improves. Okay, and during the clinical latency period, it's starts reducing very gradually, and once it falls below 400, 300, 200, then the patient starts to acquire opportunistic infection. Okay, so this is the correlation between the viral load and the CD4 cell count, and also the various phases of the HIV infection. And this is discussed earlier. So these are the clinical findings during the acute HIV syndrome. So during the acute phase, so the patient may have fever, pharyngitis, lymphadenopathy, headache or retroorbital pain, myalgias, lethargy, malaise, anorexia, nausea, vomiting, diarrhea. So like any other infection. Okay, and sometimes neurological presentations like meningitis, encephalitis, peripheral neuropathy, myelopathy can occur. The patient may present with maculopapular rash or mucocutaneous ulcerations as well. These are AIDS defining opportunistic infections. Okay, so when the CD4 count falls below 200, the patient will be at more risk of acquiring these opportunistic infections. Okay, so this includes candidiasis, okay, cervical cancer, this herpes simplex infection, and disseminated fungal infections like coccidioidomycosis, cryptococcosis, and cytomegalovirus infections, and herpes simplex, histoplasmosis, Kaposi sarcoma, all kinds of lymphomas, mycobacterium infections, mycobacterium avium complex MAC infections, and tuberculosis. Okay, so this is the most common opportunistic infection in India. Okay, so mostly patient present with reactivated tuberculosis. Okay, and then we accidentally discover that the patient will be having HIV. Okay, so TB is the most common presentation of a patient with HIV in India. And the pneumocystis jirovecii infection, bacterial pneumonia, okay, and salmonella septicemia, toxoplasmosis, and wasting associated with HIV. Okay, so these are all the AIDS defining illnesses. Okay, so the patient has any one of these opportunistic infection associated with a falling CD4 cell count less than 200, then we call it as AIDS. Okay, so antiretroviral drugs, they play a very important role in containing the viral load and also in improving the CD4 cell count. Okay, so antiretroviral drugs have to be taken lifelong, and the patient's quality of life will be improved if it is taken regularly. So the patient complaints has to be checked, and you must remember, antiretroviral drugs, they do not treat HIV infection. Okay, so we know that the virus is dormant, it is persistent in the lymphoid tissues. Okay, so it is going to be there always. So the only thing we are going to do is to keep a check on the viral load. So the RNA copies of the virus, we are going to reduce it, and also we are going to decrease the slope of the fall of CD4 lymphocytes. So as long as the CD4 cell count is above 500, the patient will be at a lower risk of getting opportunistic infection. Okay, so we are going to give a good quality of life. We are going to extend the number of years the patient going to live without acquiring or without going to the stage of AIDS. So that is the goal of therapy. Okay, so we have various antiretroviral drugs. So it can be classified into nucleoside reverse transcriptase inhibitors. Okay, so nucleoside means it is a purine and pyrimidine derivative. Okay, without that phosphate structure. So nucleoside reverse transcriptase inhibitors, NNRTIs. So you have thymidine analogs, cytidine analogs, guanosine analogs, and adenosine analogs. So thymidine analogs are zidovudine, stavudine. So zidovudine is the first antiretroviral drug which was discovered, and zidovudine, stavudine or thymidine analogs, and lamivudine, emtricitabine. These two are cytidine analogs. Abacavir is a guanosine analog, and didanosine, it is an adenosine analog. So all these are nucleosides, and you have only one nucleotide available, which is tenofovir. Okay, so it is a monophosphate, so it contains one phosphate group attached. So it is a nucleotide. The only nucleotide analog available under antiretroviral drugs is tenofovir. Okay, and then you have non-nucleoside reverse transcriptase inhibitors. These are nevirapine, efavirenz, etravirine, delavirdine. And protease inhibitors. So we know the role of protease enzyme, okay, in the viral maturation, at the end point of viral maturation. This protease has a role. So drugs which inhibits this protease enzyme are ritonavir, atazanavir, indinavir, nelfinavir, sacuanavir, amprinavir, lopinavir, and tipranavir. Okay, so those which ends with navir. Okay, so these are protease inhibitors. So this you can keep in mind while differentiating between this, abacavir and protease inhibitors. Okay, so protease inhibitors, they end with navir. And you have entry inhibitors or fusion inhibitor, so which prevents the fusion of the virus into the fusion of virus to the CD4 lymphocyte. So it is enfuviritide. and CCR5 receptor inhibitor. So we know that CCR5 receptor is a chemokine receptor which acts as a co-receptor which helps in the binding of virus to the host cell. So the drug Maravirac, it inhibits this CCR5 receptor and prevents the binding of virus to the host cell. And then you have integrase inhibitors. So this integrase enzyme is responsible for the integration of proviral DNA to the host DNA. Okay, so the drugs which inhibits this integrase are raltegravir, dolutegravir and elvitegravir.
We will now see about the first group of drugs, nucleoside reverse transcriptase inhibitors. Okay, as the name suggests, so these drugs are nucleoside analogs. So nucleoside means what? It contains a purine or pyrimidine base with a sugar. Okay, so without a phosphate. So when phosphate is getting attached, then we call it as nucleotide. So here these are all nucleoside analogs, either purine analog or pyrimidine analog, and so they are not active as such. So they have to be phosphorylated, or they have to be converted into a triphosphate form, and this triphosphate form is the active form. Okay, so you can see the mechanism of these NRTIs. So this is the triphosphate form of the NRTI. Okay, suppose if it is zidovudine, then it is the zidovudine triphosphate. This is the structure of zidovudine triphosphate, and this is the active form. Oh, we call it as anabolite. So this is the active form of the drug, the triphosphate form. So this triphosphate form, it goes and gets incorporated into the proviral DNA. Okay, so which is the daughter DNA strand which is being transcribed from the RNA by this reverse transcriptase enzyme. So this goes and binds to the active site of the reverse transcriptase enzyme, and this triphosphate form of the drug, so it is also a nucleoside, right? So it gets incorporated into the dotted DNA strand, and it causes termination of this process. Okay, so it causes termination of this chain elongation. So the dotted DNA strand gets broken. Okay, so this gets incorporated and it blocks the transcription process, and it binds to the active site of the enzyme reverse transcriptase. Okay, so it prevents the infection of new cells. Okay, so it can prevent the infection of new cells, but once already the DNA gets integrated into the host cell, these drugs cannot reverse it. Okay, so since they block the formation, or they block the production of this dotted DNA strand, it can prevent new infection, but it cannot reverse the already infected and integrated cells. Okay, so when the the viral DNA gets integrated into the host cell DNA, then these drugs cannot reverse it. Okay, so it can prevent only the new infection, and it inhibits both HIV-1 and HIV-2. So there are two subtypes of human immunodeficiency virus, HIV-1 and 2. So HIV-1 infection is more common. Okay, so HIV-2 is less common. So it is actually mostly found in the African regions, but still we have a few HIV-2 strains also. Okay, but HIV-1 is more common. So these NRTIs inhibits both HIV-1 and HIV-2. Okay, so as with any other antimicrobial agent, so these drugs also have developed resistance. Okay, so the resistance is mainly due to the mutation. Okay, so thymidine analog mutation, so we call it as TAMs. So these mutations, these are the main reason for resistance in thymidine analogs like zidovudine and stavudine. So because of these mutations, what happens? It causes pyrophosphorylases of the active form of the drug. Okay, so the active form of the drug like zidovudine and stavudine, it gets broken down, or it gets lysed, okay, by a process called as pyrophosphorylases because of this mutation, thymidine analog mutation. And similarly, M184V, this mutation is responsible for the resistance for lamivudine and emtricitabine. K65R mutation is responsible for tenofovir resistance, and L74V substitution is responsible for didenosine drug, okay, resistance of didenosine. So these are the various types of mutation which is responsible for the development of resistance of NRTIs. And pharmacokinetics, so tenofovir, the bioavailability of tenofovir increases when the drug is taken with a high fat meal. So this you should remember. And similarly, didenosine, it is a very acid labile drug and it is degraded at a very low gastric pH. So usually didenosine is buffered with a alkaline base. Okay, so some antacid buffer is always be there in the didenosine preparations in order to make the drug more stable. Okay.
The adverse effects of this NRTIs are mainly due to inhibition of DNA polymerase gamma or mitochondrial DNA polymerase. So we know that these drugs inhibit the reverse transcriptase enzyme, which is a DNA polymerase, RNA dependent DNA polymerase. So we have DNA polymerase in our cells also. Okay, so there are three types of DNA polymerase alpha, beta and gamma. Alpha and beta are located in the nucleus, and this gamma DNA polymerase is a mitochondrial enzyme. Okay, so usually this alpha and beta are not affected by these drugs, but this mitochondrial DNA polymerase gamma is affected by these drugs. Okay, so these drugs can inhibit the cellular mitochondrial DNA polymerase also, in addition to the reverse transcriptase of viral enzyme. Okay, so because of this inhibition of mitochondrial DNA polymerase, so this can cause many toxic side effects like anemia, granulocytopenia, myopathy, peripheral neuropathy and pancreatitis, and sometimes lactic acidosis, hepatomegaly and hepatic steatosis can also occur. So these adverse effects are more common with thymidine analogs. Okay, so especially zidovudine and stavudine. And emtricitabine, lamivudine and tenofovir, these three drugs have very low affinity for this mitochondrial DNA polymerase, and hence very less frequency of these adverse effects. And another side effect of these thymidine analogs, in addition to this mitochondrial DNA polymerase inhibition, is lipodystrophy. Okay, so redistribution of lipids. And stavudine and didenosine, so these two drugs cause peripheral neuropathy. So it is the most common side effect of stavudine and didenosine. So because of these two drugs should not be combined together in the HIV regimen. Okay, so because of this peripheral neuropathy, shared side effect. And abacavir cause hypersensitivity. Okay, so hypersensitivity is a more common adverse effect seen with abacavir, and this is especially more common with persons with HLA-B5701 genotype. So actually you should not give abacavir for patients with this particular genotype, and once hypersensitivity reaction occurs, so this drug should not be repeated again, it should not be given again, because the reaction can be very dangerous and even fatal. Okay, so this hypersensitivity reaction, this should be kept in mind when giving abacavir. And renal impairment is seen with tenofovir. So tenofovir should be used cautiously with patients with renal impairment. Okay, and this is the lipodystrophy. So you can see in this first picture, you can see the buffalo hump, okay, behind the neck, and also truncal obesity. Okay, and this is the facial wasting. Okay, so here facial wasting, this buffalo hump and truncal obesity, these are the cardinal features of lipodystrophy seen with the use of thymidine analogs. And here you can see accumulation of intra-abdominal fats. So the fat accumulation is seen in the abdominal area. Okay, so these are the features of lipodystrophy. Drug interactions are important point of concern because we use ART drugs in combination, so there are more chance of drug interactions. Okay, and the first and foremost important drug interaction is between stavudine and zidovudine. So both these drugs are thymidine analogs, and both these drugs get phosphorylated by thymidylate kinase enzyme, okay, so which adds phosphate group. So since the same enzyme phosphorylates both these drugs, and we know that the triphosphate form is the active form, so these drugs has to be phosphorylated in order for the drug to act. So since these two drugs compete for this phosphorylation, it should not be given together, because one drug will antagonize or inhibit the phosphorylation of the other drug. So these two drugs should not be combined. And similarly, lamivudine and emtricitabine, so these two drugs, they have same resistance pattern and same activity patterns, so they don't actually add up. Okay, so there is no rationale in combining these two drugs. And similarly, stavudine and didenosine, as we discussed earlier, both cause peripheral neuropathy. So when these two drugs are combined, there is the severity of peripheral neuropathy is more. Okay, and similarly, pancreatitis, fatal pancreatitis also, the incidence it is more when these two drugs are combined. And similarly, tenofovir, when it is combined with didenosine, so it inhibits an enzyme called as purine nucleoside phosphorylase. Okay, so this purine nucleoside phosphorylase is responsible for the metabolism of this didenosine. So when this enzyme is inhibited by tenofovir, the AUC of didenosine increases, the bioavailability increases. Okay, so whenever this drug is combined with, usually these two drugs are not combined because it inhibits the metabolism of didenosine, and the toxicity of didenosine increases. So suppose if you are going to combine, then the dose of didenosine has to be reduced many-fold. Okay, so this interaction has to be kept in mind. So tenofovir inhibits the metabolism of didenosine by inhibiting purine nucleoside phosphorylase, PNP enzyme, okay, which is responsible for the metabolism of didenosine. And similarly, zidovudine and lamivudine, so it is a positive interaction. Okay, so we know that lamivudine resistance occur because of mutation in M184V codon. Okay, so the same mutation which is responsible for lamivudine resistance actually reverses the zidovudine resistance. Okay, so zidovudine is due to a different mutation, and lamivudine resistance is due to different mutation. The mutation which is responsible for lamivudine resistance actually reverses the resistance of zidovudine, so it has a synergistic effect. So these two drugs can be combined for long-term suppression of this HIV RNA. Okay, so this is actually a positive drug interaction. So the other uses of this NRTIs, emtricitabine, lamivudine, tenofovir. So these three drugs are comparatively safer because they are less they have less affinity for this mitochondrial DNA polymerase, so they don't have very frequent side effect because of the inhibition of mitochondrial enzyme. And these three drugs are used in HBV infection also, hepatitis B virus infection also. Okay, and tenofovir, in addition, it is used against a herpes virus infection as well. Okay, so now we will see about non-nucleoside reverse transcriptase inhibitors, NNRTIs. Okay, so we will see some of the common properties of NNRTIs. So here, so this is the reverse one second. So this is the reverse transcriptase enzyme, and this is the RNA strand, and this is the dotted DNA strand which is being transcribed. And this NNRTIs, it will go and bind to non-essential site of reverse transcriptase. So we know the NRTIs, the nucleoside reverse transcriptase inhibitors, they bind to the catalytic site, actually the active catalytic site of reverse transcriptase enzyme. whereas the non-nucleoside reverse transcriptase inhibitors, they bind to a non-essential site which is distant from the catalytic site of reverse transcriptase enzyme. So they are actually non-competitive inhibitors. Okay, and also another property is they do not require intracellular phosphorylation. So we know that NRTIs need to be phosphorylated in order to act, but here this NNRTIs, they don't require phosphorylation, and these drugs are virus strain specific. Okay, so they act only against HIV-1 subtype, HIV-1 strains, and no activity against host cell DNA polymerase. So this is a important positive point. So it doesn't have action against host cell DNA polymerase, and hence it is devoid of the side effects because of this mitochondrial enzyme inhibition. So here the pharmacokinetics of this NNRTA is a little important. Nevirapine and delavirdine, so these two drugs are metabolized by CYP3A4 enzyme, whereas efavirenz, so this is metabolized mainly by CYP2B6 and to some extent by 3A4, and etravirine has mixed metabolism. Okay, so the importance of this metabolism, knowing the metabolism of these drugs, is when you combine this ART drugs with anti-tubercular drugs like rifampicin. So we know that HIV infection always coexists with tuberculosis in India. So there are more chances of giving ATT along with antiretroviral drugs. Okay, so we have rifampicin, a strong enzyme inducer in this anti-tubercular drugs category. So what happens when you combine these drugs with rifampicin? So rifampicin induces CYP3A4 enzyme, and hence it makes these drugs ineffective. Okay, so it fastens the metabolism of these two drugs, and the therapeutic efficacy falls, but not with efavirenz. Okay, so since efavirenz is mainly metabolized by 2B6, so this can be combined with rifampicin. So this is the clinical application which you should know. Okay, so since this nevirapine and delavirdine is highly metabolized 3A4, when you are combining with rifampicin, so you better give efavirenz instead of these two drugs. Okay, and again these are metabolized by these enzymes, but all these drugs, efavirenz, etravirine and nevirapine, they themselves induce this CYP3A4 enzyme. Okay, so these two drugs are metabolized by CYP3A4, and these drugs, they induce CYP3A4. Okay, except delavirdine, which is an enzyme inhibitor. Okay, so these points are important for your PG entrance exam preparation. So this can be asked in MCQs. Okay, so nevirapine, delavirdine are metabolized by CYP3A4. Efavirenz is mainly metabolized by 2B6 and to some extent by 3A4, and etravirine has mixed metabolism. And efavirenz, etravirine and nevirapine are inducers of CYP3A4 enzyme, whereas delavirdine is CYP3A4 inhibitor. So the adverse effects is mainly rashes. Okay, so rashes are more common with NNRTAs, and sometimes fatal Steven-Johnson syndrome can occur. Okay, so especially it is common with nevirapine, efavirenz and etravirine. And nevirapine in addition has hepatotoxicity, and efavirenz have neuropsychiatric symptoms. Okay, and also teratogenic. Efavirenz is a highly teratogenic drug, so it has to be avoided in pregnancy. So this point you should remember. Okay. Okay, now we'll see about protease inhibitors. So we saw NRTIs, NNRTIs, and now protease inhibitors. So we know that protease is an enzyme, okay, which is responsible for the production of structural proteins and enzyme from the large viral polyprotein. So initially from the RNA, the large polyprotein is synthesized, and from this polyprotein the structural proteins and enzymes, okay, so which are the components of HIV. They are synthesized by proteolytic cleavage, okay, so that is carried out by the aspartic protease enzyme, which we call it as protease. Okay, so this enzyme actually acts at the late step in the HIV replication maturation of the new virus particles. So at the end point of maturation, so this enzyme is responsible for budding of the active virus out of the cell. Okay, so here these protease inhibitors, these drugs, they bind to the active site of the protease molecule, okay, and it interferes with the cleaving function. Okay, so here you can see this is the gag pole. So these are all the structural protein, okay, genes, the genes for structural proteins, and this is the precursor polypeptide, and this protease enzyme actually cleaves into the effective structural proteins. So here these protease inhibitors, it will block this process, okay, so it will inhibit this protease enzyme and blocks the cleaving function of the enzyme. So all protease inhibitors are extensively metabolized by CYP3A4 except nelfinavir. Okay, so this point is very important. Okay, so pharmacokinetics of protease inhibitors also very important. So you must know all the protease inhibitors are metabolized by CYP3A4 except nelfinavir, which is a substrate of 2C19. So why this point is important? So since they are actually these drugs, they are potent inhibitors of CYP3A4 as well. So all protease inhibitors are not only metabolized by CYP3A4 but also they inhibit CYP3A4. So this inhibition of the enzyme is very important because the protease inhibitor, especially ritonavir, okay, so this ritonavir is used in addition to all protease inhibitors in a lower dose to increase the plasma level of the drug. So because this ritonavir inhibits the CYP3A4, okay, so it is combined with other protease inhibitors in order to increase the plasma level of the drug. So since it inhibits the metabolism of all the drugs, this is combined with other protease inhibitors to increase the therapeutic concentration of the protease inhibitors. So this ritonavir combination is not effective with nelfinavir because it is not metabolized by CYP3A4. So ritonavir is combined with all protease inhibitors for the boosting. So it is called as booster regimen. So for increasing the therapeutic concentration of the drugs except nelfinavir, because this drug is not metabolized by CYP3A4 but it is metabolized by 2C19. Okay, and nelfinavir, lopinavir and ritonavir. So these three drugs, they induce their own metabolism as well. Okay, so in addition to inhibition of CYP3A4, they have a property to induce their own metabolism also. Okay, so these points you should remember. So the main point is all protease inhibitors are metabolized by CYP3A4 and also they inhibit CYP3A4 enzyme except nelfinavir, which is a substrate of 2C19. Okay. Okay, so the challenges, what are the challenges we face with the use of protease inhibitors? So the most important thing is drug interaction. So since they inhibit CYP3A4, so there are a lot of interactions when we combine with drugs which are metabolized by the same enzyme. And similarly, large tablet load. Okay, so these protease inhibitors has to be given in very huge quantity. So the number of tablets the patient needed to take is very high. Okay, so this may cause poor compliance, poor adherence to the treatment. So in order to overcome this large tablet load and in order to increase the compliance, we use the boosted protease inhibitor regimen. So what do you mean by that? So when you combine the protease inhibitors with a very low and subtherapeutic dose of ritonavir, Okay, so ritonavir, the therapeutic dose is 600 milligrams, but when ritonavir is given at a dose of 100 milligrams, it acts as a pharmacokinetic booster. How? Because it inhibits the CYP3A4 enzyme and it inhibits the metabolism of other protease inhibitors, and thereby you can reduce the dose. Okay, so instead of giving a huge dose, you can decrease the dose when you combine with this ritonavir. Okay, so this is called as boosted PI regimen, boosted protease inhibitor regimen. So you must always remember nelfinavir is not combined. Okay, so nelfinavir and ritonavir is not combined because it is metabolized by, it is not metabolized by CYP3A4. The adverse effects of protease inhibitors are lipodystrophy, dyslipidemia, insulin resistance, so it causes metabolic syndrome like effects, and specifically indinavir, it causes crystalluria and nephrolithiasis. Okay, so it is very less soluble, and hence the kidney stone formation and crystalluria. Okay, so it is more common with indinavir. So whenever patient takes indinavir, he or she should be advised to take plenty of water. Okay, so in order to prevent this nephrolithiasis and crystalluria. And similarly, darunavir and amprinavir or fosamprinavir, so these are drugs which contain sulfa group, and hence it causes rash. And atazanavir, indinavir, so these two drugs, it can increase the bilirubin levels because they have a property of inhibiting UDP glucuronidase transferase enzyme. So this increases the unconjugated bilirubin level. Okay, so this is reversible, but it is a side effect which is seen with these two drugs. And similarly, tipranavir, so it causes hepatotoxicity, and also it has some anticoagulant property as well. Okay, so these are the adverse effects seen with protease inhibitors. Okay, next we will move on to the next group of drug, fusion inhibitor or entry inhibitor, enfuvirtide. Okay, so this enfuvirtide, it is actually the drug is derived from the HIV peptide. Okay, so it is a synthetic peptide which is derived from the virus itself. Okay, and it binds to the glycoprotein 41. So we all know that this GP41 is responsible for the fusion of virus with the host T cell. Okay, so this binds to this GP41 and prevents the fusion of viral and the cell membranes. Okay, so and hence the entry of virus into the cell is blocked. So it acts only against HIV-1, it doesn't act against HIV-2. And the other problem with this enfuvirtide, it has to be given by subcutaneous injections. Okay, so twice daily subcutaneous injections are needed. So these drug is always not considered in the first line regimen because of the need to give by injections twice daily. So it is a reserved drug. So it is added whenever the patient becomes resistant to other first line drugs. Okay, the next drug is Maravirac, CCR5 receptor inhibitor. So this is also an entry inhibitor. Okay, but it blocks the CCR5 receptor, which is a chemokine receptor, which acts as a co-receptor. So we know this CCR5 receptor is essential for this CCR5 receptor along with the CD4 receptor. Both are essential for the binding of HIV virus to the host cell. Okay, so this Maravirac, it blocks the CCR5 receptor. Okay, and it prevents the entry of virus into the cell. Okay, and you should know this drug acts only on CCR5 trophic HIV strains. So we know that there are two chemokine receptors, CCR5 and CXCR4. Okay, so some HIV strains are CCR5 trophic and some HIV strains are CXCR4 trophic, and some strains are mixed, they are both CCR5 and CXCR4 trophic. With this drug's Maravirac, it acts only on CCR5 trophic HIV strains. It doesn't act on CXCR4 or mixed trophic HIV strains. So this point you should remember. So only CCR5 trophic HIV strains are affected by Maravirac. Okay. Okay, the next one is integrase inhibitor. So we know integrase is an enzyme which is responsible for the integration of this proviral DNA with the host DNA. Okay, so here the drug raltegravir, so it is an example of integrase inhibitor. So this drug, it acts on this integrase enzyme. Okay, and it prevents the integration of this proviral DNA with the host DNA. Okay, so it acts both on HIV1 and HIV2, and we have another integrase inhibitor called as elvitigravir. So this elvitigravir, it is not available as a single drug. So it is available always in combination with cobicistat, tenofovir and emtricitabine. So what is this cobicistat? So it is the action of this is similar to ritonavir. It doesn't have any antiretroviral property, but it has the enzyme inhibiting property. So when combined with this drug, it increases the therapeutic concentration of elvitigravir. Okay, so this elvitigravir, it is always available in combination with these three drugs. Okay, so that's all about the antiretroviral drugs. Now we will move on to the treatment aspect. Okay, so we will see the HIV treatment principles and various guidelines. Okay, so for the treatment of HIV infection, we always use HAART, HAART. So that means highly active antiretroviral therapy. So which means the drugs are always used in combination. Minimum 3 drugs combinations are used. Okay, so no antiretroviral drugs is used as a single drug. Okay, so when you use as a single drug, there is always a chance of development of high resistance. So then you cannot use that drug again. So never use any antiretroviral drugs as a single drug. So it is always used in combination, and that therapy is called as highly active antiretroviral therapy. And the goal is actually to maximally and durably inhibit the viral replication. So the goal is to reduce the viral replication as far as possible, and also to reduce the infectivity and limit the transmission. So when the viral load is reduced, so you are reducing the infectivity, okay, and also the transmission. So when you call it an optimum response for the treatment, when the reduction of the plasma HIV RNA, it falls to an undetectable level. So that means less than 50 copies per microliter within a period of 6 months, then we call it as an optimum response to your ART therapy. Okay. Before we see the management of HIV disease, we will see the clinical staging, okay, which is defined by World Health Organization. So you have 4 clinical stages in HIV infection. So stage 1 is mainly asymptomatic, those who are asymptomatic, and those with persistent generalized lymphadenopathy. Okay, so when they are asymptomatic and they have generalized lymphadenopathy alone, then they are categorized as stage 1. And stage 2, so they will be having moderate unexplained weight loss, less than 10% of body weight. So the weight loss should be there, with recurrent respiratory tract infections, herpes zoster infection, angular cheilitis, recurrent oral ulceration, and skin eruptions, fungal infections of nail and seborrheic dermatitis. So when either of these symptoms are present, then it is called as stage 2. And stage 3, unexplained weight loss more than 10% body weight, and chronic diarrhea for longer than 1 month. So unexplained chronic diarrhea. Okay, so no other etiology can be attributed for the diarrhea. And unexplained persistent fever, either intermittent or constant for more than 1 month, persistent oral candidiasis, oral hairy leukoplakia, pulmonary tuberculosis or severe bacterial infections, acute necrotizing ulcerative stomatitis, and unexplained anemia less than 8 grams per deciliter, or neutropenia or chronic thrombocytopenia. So when any of these are present, then they are staged as clinical stage 3. Okay, the last stage is stage 4. So here we see all the AIDS defining opportunistic infection which we saw earlier. Okay, so the patient be having all the opportunistic either of these opportunistic infections, then they are categorized as stage 4. So these are the opportunistic infection. Okay, so this is the oral thrush by candidiasis, and this one is the hairy leukoplakia. Okay, you can see the thickening here, and this is the aphthous ulcer. Okay, and this is Kaposi sarcoma. Okay, malignancy. And we saw the clinical staging, and there is also immunological staging. Okay, so you should consider the CD4 levels also. So this should always be correlated with your clinical findings, okay, in order to decide the ART therapy. So when the CD4 levels is more than 500 per cubic millimeter, then there is no significant immunosuppression. But when the cell count is between 350 to 500, it means mild immunosuppression. When it is between 200 to 350, it is advanced immunosuppression, and when it is less than 200, then it is severe immunosuppression. Okay. Okay, so we know that ART is the main line of management for HIV infection. So NACO, which is called as National AIDS Control Organization. So this is the organization under Ministry of Health and Family Welfare. So this organization is responsible for implementing the National AIDS Control Program. Okay, in India, this NACO is responsible for implementing the AIDS control program. So the first national AIDS control program was started in 1992, and after that you have NACP 1, 2, 3, and recently NACP 4 is being implemented in 2017. So this is the latest national AIDS control program. So the aim of or goal of this NACO or National AIDS Control Program is to eliminate HIV infection by 2030. So that is the aim, and at present the prevalence is 21.40 lakhs. So at present these many people are being affected by HIV infection. Okay, so we see a good reduction in the mortality due to successful implementation of ART. So the implementation of ART is the main it's the main action of this national AIDS control program. Along with this, they also conduct many IEC campaigns in order to bring about behavioral changes in the people, so to prevent the infection and transmission. Okay, so they implement various education programs, they distribute pamphlets, they create awareness among the people about the mode of spread of HIV, and also how to be safe. Okay, so all these information is also they are given to people by this organization, in addition to implementation of antiretroviral therapy. So we know that there are ART centers in various medical colleges, district hospitals, and also primary health centers. Okay, so there they are giving this antiretroviral drugs free of cost. So the government is giving antiretroviral drugs free of cost. So all these implementation process are managed by this National AIDS Control Organization. So when is ART given? So this is always a point of contradiction. Okay, so some say earlier the ART initiation, better will be the outcome, and some say that ART always have it comes with very serious adverse effects. So ART should be given only when the patient's the immune status is under threat. So there are so many contradictory opinions. According to NACO, so ART therapy is always based on this WHO clinical staging. So the clinical stage 1 and 2 Okay, so if we have to start ART only if the CD4 count is less than 500. So if the patient is asymptomatic and if the CD4 count is more than 500, you need not start ART. And similarly, in clinical stage 3 and 4, we have to start ART irrespective of CD4 count. So that means stage 3 and 4, immediate ART should be started, and for stage 1 and 2, ART should be started when the CD4 count falls below 500. And all pregnant and breastfeeding women, irrespective of clinical stages, we have to start ART. Okay, so irrespective of clinical stages, irrespective of CD4 count, ART should be started for all pregnant and breastfeeding women. And when the patient is co-infected with TB, HIV TB co-infection, then the patient has to be started on ART irrespective of CD4 count. So when starting this ART or when starting this ART and ATT, anti-tuberculous therapy, so which one to be started first? Suppose when you see the patient who has both HIV and TB, so which treatment you will start first? So you always have to start ATT first, and then initiate ART as early as possible. Okay, so within a period of 2 weeks to 2 months, then you can start ART. So why ATT should be started first? Because when you start ART, what happens? The patient's immune status improves. Okay, the CD4 count increases, the patient immune status improves, the latent tubercular infection, okay, it gets reactivated, or the immune reaction to the latent tubercular infection, it causes reactivation and increase in the symptom of the opportunistic infection. Okay, the TB symptoms and signs, everything eases when the patient immune status improves with ART. So this we call it as immune reconstitution inflammatory syndrome. So it can be dangerous sometimes, it can be even fatal. Okay, so these immunological response to the latent tuberculosis infection can be fatal. So first we have to start ATT. Okay, so we have to bring down that tubercular bacilli level also, and then you have to start ART, so in order to prevent this inflammatory response. Okay, and when there is HIV hepatitis B and C co-infection, you have to start ART if the CD4 count is less than 500, and when there is chronic liver disease also. Okay, so when the HIV co-infection with HBV or HCV is associated with severe chronic liver disease, then ART has to be started irrespective of CD4 count. And when HIV is associated with visceral leishmaniasis or Kala-Azar, then you have to start ART irrespective of CD count. So these are the guidelines when to start ART. So these are the guidelines which tell us when to start ART according to NACO. This is the first line regimen recommended by NACO. Okay, so when you see the regimen, you can see there are always a combination of 2 NRTIs with 1 NNRTI. Okay, so this is the preferred combination. In a 3-drug combination, 2 drugs will be from NRTI group and 1 drug will be from NNRTI group, and protease inhibitors are always reserved for second line regimen. Okay, so because protease inhibitors have a more frequency of developing resistance, more prone for developing resistance, they are reserved for second line regimen. And so lamivudine is always a preferred drug in all combinations. Okay, so that you can observe here. And whenever zidovudine cannot be used in cases of anemia, so zidovudine is more prone to cause anemia. So especially when the hemoglobin levels goes below 8 grams, then you cannot use zidovudine. So in that case you can use stavudine. Okay, and when both these drugs cannot be used, then you can prefer tenofovir. Okay, so then nevirapine and efavirenz are the preferred NNRTIs. So suppose the patient cannot tolerate nevirapine and efavirenz, then you can go for 3 NRTA regimens. Okay, so 3 drugs all from nucleoside reverse transcriptase inhibitors group, lamivudine, zidovudine and tenofovir. And So protease inhibitors, they are always reserved for advanced cases, okay, who have failed the earlier regimens, and no drug holidays or structured treatment interruptions recommended. So that means suppose if the patient develop an adverse reaction, okay, then you cannot interrupt the regimen, okay. So because when you give any interruption, so there is always a chance of high viral replication, and also increased chance of resistance development. So the ART treatment should be continued without interruption, and also the treatment is lifelong, okay. So the drugs cannot be stopped at any point of time. And similarly, when you are giving this ART, so heart means what? Highly active antiretroviral therapy. So when you are instituting ART in patients with latent or partially treated opportunistic infection, so which we discussed earlier. Suppose if the patient had latent tuberculosis, then it can produce immune reconstitution syndrome, okay. So which is called as iris syndrome, immune reconstitution inflammatory syndrome, which is called as iris. So you should always keep in mind about the syndrome. So you should first start treating that opportunistic infection before instituting ART, okay, in order to prevent this syndrome. And pregnancy is not a contradiction for ART, so ART should be given for all pregnant patients. So you should avoid efavirenz, okay, because it is teratogenic, but other drugs you can give. And suppose a patient is not responding to ART, suppose or resistance has been developed for one drug, okay. So that or optimal response is not obtained. So we saw that the optimal response is the undetectable viral load less than 50 copies within a period of 6 months. Suppose that optimal response is not achieved, okay, then you have to change the entire regimen. So all the 3 drugs has to be changed, okay. So you cannot just take away one drug and you cannot add one drug, okay. So suppose the patient is taking lamivudine, zidovudine, nevirapine, and the response is not obtained, or the patient has developed resistance to any one of these drugs, then you have to change the entire 3 drugs and you have to replace with other 3 drugs, okay. So which does not have these any one of these drugs. So the entire regimen has to be changed. And suppose the first line regimen has failed, suppose the patient is not showing adequate improvement or adequate response with first line regimen, then you have to consider the second line regimens, okay. So here you can see there is no NNRTA, because when NNRTA is used for the first time, okay, so almost all patients will be developing resistance. So there is no point of using NNRTA again in second line regimen, okay. There is more frequency of cross resistance between different NNRTA groups, so there is no point in using NNRTA again in second line regimen. So you can see no NNRTA here, okay. So there is no role of non-nucleoside reverse transcriptase inhibitors, but protease inhibitors are added in second line regimens, okay. So here the standard regimens are tenofovir abacavir combination, didanosine abacavir, tenofovir zidovudine, tenofovir lamivudine. So two NRTIs plus one protease component. So any one of this protease inhibitor with 2 NRTIs. So that is preferred second line regimen. So in special circumstances you can have these 2 combinations. These are the standard regimens, and these 2 are for special circumstances where these drugs cannot be given, okay. So lopinavir, so here R means ritonavir boosted regimens. So protease inhibitors, so it is always given as a boosted regimen along with ritonavir, except nelfinavir, okay. So nelfinavir is not boosted. And always the drug sensitivity testing should be done before starting second line regimens. Why? The patient has failed the first line regimen, so we should screen for that viral resistance, okay. So the viral resistance testing should be done, and then appropriate drug second line drug should be selected. Okay, and in addition to this NRTIs and protease inhibitors, you can also add integrase inhibitors, CCR5 inhibitors, or fusion inhibitors. Okay, so these drugs can be added on need basis in second line regimen. Okay, so that's all about management. Okay, and now prophylaxis, post exposure prophylaxis. So we know that HIV is transmitted by parental route and sexual route. So parental route transmission can be either by a needle prick injury, okay, or by blood transfusion. So needle prick injury is always common among the healthcare professionals. Okay, so those who have been accidentally exposed to such kind of needle prick injury, or splashing of blood during surgeries, so such kind of exposure can accidentally happen among healthcare professionals. So for them, post exposure prophylaxis is given in order to suppress the local viral replication. So prior to dissemination, we are suppressing the viral replication. So the exposure can be either of low risk or high risk. So low risk exposure means when the source is HIV positive. So whenever the patient, okay, for example, he or she is HIV positive, but they are asymptomatic, and their HIV RNA titer is very low, and their CD4 cell count is very high. So that means they are in stage 1, clinical stage 1 HIV disease. Then it is a low risk of exposure. And similarly, if the exposure is through mucous membrane or superficial scratch, okay, or through a very thin solid needle, then the exposure is low. So high risk exposure means when the source is symptomatic, AIDS patient with high HIV RNA titer or very low CD4 count, then the risk is high. And similarly, if the exposure happens through a very major splash or large area contact of very longer duration with mucous membrane or abraded skin, or through large bore hollow needle or very deep puncture, or visible patient's blood on the needle. So when these happens, then it is a high risk exposure. Okay, so here the preferred drug for post exposure prophylaxis is zidovudin 300 milligrams plus lamivudin 150 milligrams twice daily for 4 weeks. So this is the 2 drug regimen. So this 2 drug regimen is recommended for low risk exposure, and for high risk exposure 3 drug regimen is preferred. So here zidovudin lamivudin is combined with one protease inhibitors, so taken twice daily or thrice daily for 4 weeks. So this is for high risk exposure. Okay, so here nevirapine is not recommended for post exposure prophylaxis because of its hepatotoxicity, and this prophylaxis should be started as early as possible. Okay, so preferably within 1 to 2 hours of exposure you have to start this PAP, and PEP is not effective after 72 hours. So when you start this after 72 hours, it's not going to be effective. So this is about post exposure prophylaxis. And another prophylaxis is perinatal HIV prophylaxis. So we know HIV is transmitted from mother to child, okay, during pregnancy and also during the birth process and after pregnancy through lactation. So in all these stages, HIV can be transmitted, and among these, the highest risk of transmission is during the birth process. So that's why whenever the mother is tested positive for HIV, always cesarean section is performed and vaginal delivery is not recommended. Okay, because there is high risk of transmission. And the preferred combination of drugs are zidovudin, lamivudin and nevirapine. So ART should be started as soon as the mother tests positive for HIV. And this ART should be continued through delivery and into the postnatal period as well, and strictly breastfeeding should be contraindicated. Okay, so the 2 things you should remember is HIV positive patient should always deliver through cesarean section, and breastfeeding should be strictly contraindicated because HIV is transmitted through breast milk as well. Suppose you see a patient during labor only, and if she is HIV positive, okay, and she has not taken any ART before, so even then you can start zidovudin. Okay, you can start zidovudin during labor, and then you can give zidovudin to infant also. Okay, so this can be protective to some extent. So this is perinatal HIV prophylaxis. So prevention is always better than cure. Okay, so we know that there is the HIV infection cannot be cured in total because of the property of these virus to become persistent or to remain latent in your lymphatic system. So you cannot eradicate the HIV virus in total. So the better way is always to prevent. So prevention can be done by education, counseling, and behavior modification. Okay, educating the people to use barrier contraceptives and adult male circumcision. Okay, so this can decrease the risk of HIV infection, and avoiding sharing of needles. So two routes of transmission: parental route and sexual contact. So parental route is mainly by IV drug abuse. So this can be prevented by proper education, counseling, and behavior modification. Okay, and barrier contraceptives in order to prevent sexual transmission. So prevention is always better than cure. To summarize, so these are the various antiretroviral drugs and their site of action. So we have nucleoside reverse transcriptase inhibitors and non-nucleoside reverse transcriptase inhibitors. So they block this reverse transcriptase enzyme, okay, and it which converts or which transcribe the viral RNA into double-stranded DNA. So NRTI acts on the active catalytic site of the enzyme, and the NNRTI acts on the non-essential site of the enzyme. So the NNRTI is a non-competitive inhibitor, and you have protease inhibitor, which acts at the last step of viral maturation. Okay, so which is responsible for cleaving of the protein and production of the structural proteins. So protease inhibitors, it prevents the cleaving process of protease enzyme and viral maturation. And maraviroc is a chemokine receptor inhibitor, CCR5 receptor inhibitor, and which blocks the attachment of the virus into the CD4 lymphocyte. And enfuviritide, so it is a fusion inhibitor. So this blocks the glycoprotein 41, which is responsible for the fusion of virus to the CD4 lymphocyte. And integrase inhibitors, it inhibits the integrase enzyme, which is responsible for integration of proviral DNA into the host DNA. Okay, so these are the various sites of action of antiretroviral drugs. So NRTI, you should remember, the main adverse effects are due to inhibiting the host cell mitochondrial DNA polymerase enzyme. So because of that, we have various side effects. And zidovudine, the main side effect is anemia, lactic acidosis. Okay, and stavudine, you must remember, peripheral neuropathy. And NNRTIs, the main side effects are rash, okay, rashes and Steven-Johnson syndrome. And protease inhibitors, the most important thing you should remember is the inhibition of the CYP3A4 enzyme. Okay, so because of this property, the ritonavir, it is always combined with other protease inhibitors to increase the therapeutic concentration of the protease inhibitors, except nelfinavir. Okay, so that you should keep in mind. And so these three drugs, maravirac, enfuviritide, and raltegravir, so these three drugs are reserved drugs, so which can be used in the second line regimen. So while instituting ART, so you should always consider the clinical staging and the CD4 cell count. And so 2 NRTIs and 1 NNRTA is always the preferred combination. Suppose NNRTA cannot be given, 3 NRTA drugs can be given, okay, as a first line therapy. So the treatment is always lifelong. And for second line regimen, NNRTA is not given, so only 2 NRTAs and 1 protease inhibitor is given, and these drugs can be added on need basis, okay, or other drugs like the integrase inhibitors, fusion inhibitors. So these drugs can be added in the second line regimen. So you should always aim at preventing, and you should know about National AIDS Control Organization, and they are responsible for implementing National AIDS Control Program. Okay, so the goal of the therapy is to reduce the HIV RNA copies to less than 50 copies, okay, within a period of 6 months. So that is the goal. So you should always check for the patient compliance. So that is very important. Okay, so these are all the references. Thank you.